Thank you very much, Yannis, for the introduction. So this is MitraClip, and this is TEER. You've seen a DMR case from Hygeia Hospital. And there are still surgeons around that say, oh, you know, MitraClip is Alfieri, and Alfieri doesn't work. And this is still being said in many congresses. And Alfieri himself says, is not Alfieri stitch, because to begin with, you apply it with the heart beating so you don't distort the valve. And you grasp the leaflets from below, so you elevate the subvalvular apparatus, and you end up having a smooth coaptation. But the most important thing is you evaluate the result real time. You've seen the Hygeia case just now, opening, closing a few times to optimize the outcome. This is something that you can do when you have full hemodynamic loading, real-time TEE, and you can assess the results. So you can be as specific and as detailed as you like. So it's now 20 years since the first application, so it's not a new technology. And Everest 2 set up the stage for a technology going head-to-head with surgery, very bold at the time, very bad trial, I mean, crazy trial, people eligible for surgery, randomized to MitraClip versus surgery 2-to-1, but it still worked. It showed that it is safer and as effective, although in the first 6 months, a few patients had to be crossed over to surgery. And then we had the big bet. What will happen if you apply this technology to functional mitral regurgitation, reduced ejection fraction? Now, COAPT trial came, and indeed, COAPT has been the game changer for this. MitraFAR was a negative trial, and we all tried, and it's beyond the scope of this discussion to look at the differences between the two patient populations. But clearly, COAPT trial, with a very rigorous protocol, extensive review of the patients and very, very close follow-up now, reached 5 years. So these are the inclusion criteria almost all of you are familiar with. Ejection fraction between 20 to 50% and systolic diameter less than 70 millimeters. So they're not small ventricles, they're big ventricles. Of course, patients have been symptomatic, they had to be symptomatic, they had to have severe MR, and they had to be either hospitalized or had a baseline pro-BNP over 1,500. Incidentally, these are the criteria that have been put by the Greek government as a law in order to accept patients for functional mitral regurgitation in TEER. This is the follow-up of the patients now 5 years out, and you can see the follow-up has been pretty good, 89% in the MitraClip arm, 84% in the medical treatment. We've all seen the 2-year outcomes of the COAPT trial. That was a tremendous reduction of the primary endpoint, which was heart failure for hospitalization, with a number needed to treat about 4.5 patients. This is 5 years out, and the improvement is still there. And if you look at the safety endpoints at 12 months, you can see the device-specific events was 1.4%. Only 0.7% SLDA, leaflet detachment. And if you look at the safety endpoints at 60 months, these were all driven by further progressive heart failure unrelated to device complications. If you look at the device-specific events, they were identical. So durability, which is a major concern, is there. You don't have any adverse effects by the device 5 years out in this fragile population. Now, look at the combined endpoint, death or hospitalization. Still, the curves are away of each other, still statistically significant at 5 months. And if you look at the subgroup analysis, consistently you see improvement in all subgroup analysis, MitraClip versus therapy, first heart failure hospitalization, still 5 years out in favor of CLIP. It's very interesting, however, that if you dissect this data to the patients from the 3 years onwards, there's no difference to the first heart failure hospitalization. And all-cause mortality alone is still maintaining difference statistically. But if you dissect the curves from 2 years out, they don't show any difference. So mortality 2 years later doesn't deviate the curves. And that is interesting because there was pre-specified ability to cross over these patients from the control arm to the treatment arm. And as you can see, this crossover was done in 44.9% of the control patients. So what is happening to these crossover patients at 2 years? As you see, this yellow line goes in parallel with the treatment line. So MitraClip and medical therapy, if you cross over the patients at 2 years, the patients that are alive at 2 years, because a few of them are dead, then you have a parallel curve. So obviously the curves will not deviate 2 years later, because if you cross over 44.9% of the patients from the control to the treatment arm, obviously the magnitude of benefit will be offset. What is also quite interesting is what is happening to the NYHA class of this population. Clearly there's improvement of the NYHA class at all time points in favor of the MitraClip. But what is also interesting is that the class 3 and class 4 disappear on the way, because unfortunately they become black, and black means death. So a few people die on both arms, and this is unfortunately a hallmark of heart failure patients with reduced ejection fraction. What is also interesting is that MR improves, and MR is a lot better to the device arm compared to the control arm. But look what happens at 5 years. Device and control, they've got similar degree of mitral regurgitation. Why is that? Is that the medical therapy improves? Unfortunately, the patients that had severe MR have perished up to 5 years. So the surviving patients on both arms, and of course in the control arm, is a selection bias, if I may use this expression. These are the ones that are alive. So if for some magical reason with optimizing the medical therapy, your MR gets better in the control arm and you haven't had a crossover, then you stay alive at 5 years. So that's another surrogate to show that the mitral regurgitation degree is a marker of mortality in this population. Of course, there is the all-cause death-prone to bias, and there was no blinding in this population, and we have to take into account the fact that this was Gen 1 MitraClip in most of these patients, Gen 2 basically NT, but Gen 2 and Gen 1 are identical in terms of the footprint of the device. Gen 3 and the Gen 4 that we're currently using wasn't used in this population. But also the medical therapy, although they made rigorous attempts to optimize medical therapy before entering the trial, and they were very good at it, much better than the MITRA-FR population, still we didn't have ARNIS and we didn't have SGLT2. And if you look at the population, only a minority of patients were treated with this. So it would be interesting to see what if we had another COAPT trial in the contemporary era that we use all these medical guideline-directed medical therapies. Would that have minimized the impact of reduction of mitral regurgitation? We feel that is not going to be likely. But it is quite interesting that perhaps we would have less patients entering the trial, but those of these patients that would enter the trial would have higher chances to be alive at 5 years out, because we would have combined TEER with an optimized medical therapy, the contemporary medical therapy. And I have to say that it's only 5, 6, 7 years since this trial was initiated, and we have so much better medical therapy compared to what we had when COAPT was initiated. So, in conclusion, this COAPT trial showed that clearly patients with optimal medical therapy that was treated with TEER, they had a safe treatment and they had improved survival and hospitalization at 5 years, and that was across the board with pre-specified groups. The symptomatic status was improved, at least to the alive patients at 5 years out. Of course, we had this offset of the treatment effect because MitraClip crossover therapy was done in almost half of the patients at 2 years, and these patients actually got a better prognosis, similar to the patients originally assigned to MitraClip therapy. So even at 2 years out, the alive patients will still have the same benefit. But unfortunately, half of the control group had already died before they were able to cross over. So this maybe follow the initial discussion we had this morning about, yes, we need to optimize the medical therapy before entering a MitraClip percutaneous therapy like TEER. But should we wait too long to do that? At 2 years, half of the patients were dead while they were trying to optimize the medical therapy. And of course, appropriate patients with TEER should be treated as early as possible. And of course, we have to acknowledge the abysmal numbers that in both groups, 91% of the control group were dead at 5 years and 73.6% of the device group has also been dead at 5 years. So is what Steve Bolling said in the recent TVT, what do you see when you see the 5 years outcome of COAPT? I see dead people. It's very, very notorious, and it's a bad saying to do, but it is true. And that reflects on the bad outcomes of heart failure, that we need to be much better in treating these heart failure patients. Of course, MitraClip has entered the guidelines for this population. It's 2A now, both ends of the Atlantic. And it can do the job. This is one of our patients 11 years out. You can see that there's only mild MR, and this patient survived to be able to treat it with ARNIs and with SGLT2 inhibitors, and he's in an excellent state 11 years after application of the MitraClip therapy. And we have to say that Gen 4 for MitraClip and Pascal it offers more options now for these patients. And if you look at the results in the COAPT, +2 MR was about 50% of these patients. Now +2 MR is less than 14% of this population. So actually we have much better outcomes, technical outcomes, with this device, the current iteration of the devices. So the COAPT trial is a true game changer for the treatment of secondary mitral regurgitation in the patients of guideline-directed medical therapy. It definitely set the stage of the field in mitral valve intervention. All this effort that industry is making to optimize outcomes, to perhaps TMVR replacement in order to eliminate the residual MR, that's another topic that we'll discuss later on, would never ever have happened if COAPT trial was a negative trial. The field would have been dead. Everybody acknowledges that, and I think COAPT was a game changer for that regards. It is the only proven therapy so far that has been randomized against medical therapy when it comes to secondary mitral regurgitation, showed benefit, and this magnitude of benefit is such that it's comparable to the secondary prevention that ICDs are offering in patients with previous cardiac arrest in heart failure. And of course, the overall poor outcomes of the advanced heart failure population at 5 years show the need for improved heart failure therapies. Thank you very much for your attention.
Thank you very much, Vlas, for this wonderful discussion. Definitely, as we saw in the COAPT study, guideline medical therapy is number one. Resynchronization as needed, obviously needs to be applied, and then device therapy as a third. But in real-world practice, sometimes we see patients who are hemodynamically unstable with severe secondary MR. In those patients, many times we don't have the time to wait for medications and the CRT devices. Do you have any comment on that?
Absolutely. It's an excellent question and an excellent comment, and this is exactly my point. We did have a lengthy discussion about how we need to spend time to optimize medical therapy before getting a TEER therapy to this population. We all agree on that, and this was the rigorous criteria set by the COAPT, but sometimes you just simply cannot titrate your medication up. Patients are unstable, they've got low blood pressure, they're in and out of the hospital using IV diuretics. How can you escalate treatment with ARNIs? How can you put SGLT2? Are these therapies tolerated? And the bigger question, in my opinion, is how long should you spend trying to titrate this therapy? 1 month, 2 months, 3 months? You know, half of these people were dead at 2 years just trying to optimize therapy. At 6 months, a significant proportion also died. And we see that, you know, if you spend too long trying to optimize the therapy, the patient comes in bad state and they just perish. So I think we have to keep a balance. And this discussion that we had this morning about the interventional heart failure specialist that Dr. Dangas mentioned becomes very, very relevant to this.
I think, Vlas, this is very important. But we have to remember that we have to do these therapies in a timely fashion. We shouldn't let these patients have more and more dilated hearts. And please, Nikos.
Hello, Vlas, congratulations, excellent overview. A quick question: COAPT definitely is a game changer. Is one study enough, you think, to change the game? There's a negative study from France, there's the Reshape who goes on forever. What do you think?
You and I, Kostas and Michalis, have spent, I don't know how many patients. We did over 210 patients on the Reshape trial. I mean, you've been there, you know that. Reshape has been a very difficult study to do. These are very, very difficult studies to do. And if you look at the paradigm that Triluminate gave for the tricuspid field. The industry does not want to support another COAPT trial. It's a multi-million-dollar investment, and it's very difficult to conduct. It requires discipline from the investigators, very close monitoring of the patient. It's very difficult. I think the magnitude of the benefit in this trial is such that, in my mind, I mean, it's a personal opinion, there's little doubt, and we see that on a daily practice, and guidelines are endorsing it now, that if you treat well the functional mitral regurgitation, you give huge benefit to this patient.
Okay. We have two final comments before going to the satellites. First by Dr. COAPT and so Peter.
Yeah, thank you very much, Vlas. Excellent explanation. I always wondered, those patients that went to MitraClip, you know, that after 2 years, what was the selection of those patients? So why were there patients that were still continuing on medical therapy? So might there be a selection bias?
These were the patients in the control group that were still symptomatic and had severe mitral regurgitation, and they were being offered the option to cross over to the medical therapy. And of course, that depended on the patient choice, but it's very impressive that out of this population, half of them, 44.9%, crossed over. So to my mind, people just agreed to it because they were very symptomatic, or they didn't agree because perhaps there were this minority of patients that eventually ended up having less mitral regurgitation because of medical therapy kicking in at some point. And you know, they just didn't have it, and they were the ones that were alive at the end. But these were only 10% of the control group. I mean, it's really depressing to see how this control population went. And what is interesting is that 2 years, this patient derived the same benefit that the initial cohort had derived 2 years. So the surviving curves were identical. So that shows that the treatment is powerful even 2 years later.
Good. Theo, you wanted to comment?
Just quick question, Vlasis, congratulations. According to your clinical and interventional perspective, which patients are suitable for H2H and which patients are suitable for TMVR?
That's a huge topic, Theo. Clearly, if you have an anatomically suitable patient that fits the COAPT criteria, you have to do it. I think it's malpractice not to do it. Of course, you need to titrate medical therapy and give all the other options like CRT, but if you have an anatomically suitable patient plus COAPT-like criteria, you have to do it. Now, the TMVR discussion goes in when you're non-suitable for TEER or limited suitability for TEER, like the red lights and the yellow lights according to the American criteria. And then, of course, you have to apply your common sense knowledge in recruiting these patients. Now, TMVR is a huge topic that we'll analyze, but if you screen 10 patients for TMVR, at least with most of the investigated technologies, probably 2 of them would be accepted. Yeah. So that's a very big discussion.
Actually, there's a specialized session later.
But so it's a very good question.
We have to leave it there. So thank you, Vlasi. So.